Welcome to Quaderno Academy, empowering excellence through education. Join us as we inspire growth and unleash your potential. Let's dive in.
Welcome back to the Deep Dive.
Glad to be here.
So today, we're plunging into the world of rehabilitation. And specifically, we're looking at a practice that, well, it often gets a bit of a bad rap.
You could say that. It's often seen as a compromise, a way to manage budgets and wait lists.
Exactly. A necessary evil. But what we're going to explore is whether that's true. We're talking about group therapy.
And the research we've looked at suggests it's much more than that. It can actually be a profoundly effective clinical tool.
Right. So that's our mission for this deep dive.
Yeah.
To really compare the models across the three big rehab disciplines: physical therapy, occupational therapy, and speech therapy.
We want to see how they use groups, what they focus on, and what the hard data says about effectiveness.
And really get to the bottom of it.
Yeah.
Is putting patients in a group a clinical step down, or is it a legitimate, maybe even better, path to recovery?
And let's just start with the big overarching finding, because it runs through everything we read. Group therapy is widely used, it's feasible, and it's generally effective, not just for the obvious functional outcomes, but for things like patient satisfaction and a psychosocial well-being.
But, and I'm guessing there's a but.
There's always a but. The strength of that evidence, it really does vary quite a bit. It depends on the discipline, the condition, and who you're treating.
Okay, so let's get into the fundamentals. Why groups in the first place? Beyond the obvious.
Well, the obvious is a pretty powerful driver. You really can't ignore the practical side of this. Healthcare systems are under enormous pressure.
Sure.
So group therapy is an answer to very real challenges. It's about efficiency, it's about making care more accessible to more people, and it's absolutely about cost effectiveness.
Right, addressing those long wait lists we hear so much about.
Exactly. As demand for rehab just keeps rising, especially for chronic conditions, group formats become an essential strategy.
I get the efficiency argument, I really do. But if you're the person recovering from, say, a major injury, your first thought isn't what's most cost-effective, it's what's best for me.
And that is the fundamental tension. It's the question that drives all the research.
So what's the answer?
The answer, and this is probably the single most important clinical finding we have, is that group-based interventions often produce outcomes that are comparable to individual care.
Comparable.
The technical term you see over and over is non-inferior.
Let's just pause on that for a second. Non-inferior. That feels like a game changer.
It is.
Because it suggests that whatever you lose in direct one-on-one attention from the therapist, something else is making up for it.
Precisely. That's the critical finding that justifies the whole model. This isn't just about saving money anymore. It suggests the group itself, the camaraderie, the peer motivation, seeing someone else succeed, is an active therapeutic ingredient.
It's part of the medicine, so to speak.
It is. That shared journey creates a kind of social support you just can't get in a one-on-one session. And we see hard examples of this, especially in TT.
Like with knee osteoarthritis.
A perfect example. You take these structured group PT programs, exercise, education, and their clinical effectiveness is right up there with intensive individual care.
So this non-inferiority thing, it's what makes it a valid clinical choice, not just a logistical one.
Exactly. It proves its worth for measurable outcomes and patient satisfaction. And that psychosocial boost, that's something we see across all three disciplines.
Okay, so we've established that the benefits are shared. You get comparable clinical results plus this big psychosocial lift. And this is where it gets really interesting for me. The way PT and OT use groups is just fundamentally different.
It is. The difference really reflects the core philosophy of each profession.
So let's start with physical therapy. PT groups seem to be all about function and structured movement.
Right. The focus is heavily weighted toward biomechanics. It's about strengthening, endurance, balance.
Yeah.
Very concrete, measurable exercises.
And the formats reflect that, I imagine.
Very much so. They are often task-oriented, like circuit training. And circuit training particularly comes up again and again as being highly effective for neurological populations.
People recovering from a TBI or a spinal cord injury, for example.
Exactly. The success is often measured in very clear ways. How much faster can you walk? How many reps can you do? How's your balance improving?
And you need to keep those groups to a manageable size, I guess, for safety.
Yeah, the recommendation is usually up to about 10 people, so the therapist can still provide safe and effective supervision.
Okay. So that's PT. Now, let's contrast that with occupational therapy. It seems like their focus is much broader. It's about participation and meaningful roles.
That is a huge philosophical distinction. OT groups are occupation-based. They're focused on improving a person's ability to engage in, well, in life.
So not just strengthening the hand, but being able to cook a meal for your family again.
Perfectly put. It's about daily activities, domestic chores, hobbies. For PT, the activity is often the means to improve physical function. For OT, successfully doing the activity is the goal.
Which means success has to be measured differently.
It has to. You have to include those subjective things like role satisfaction, a sense of purpose, feeling engaged in doing again.
And that's probably why we see OT groups scoring so high on patient satisfaction.
Absolutely. They tap directly into what's meaningful for the patient. We see it in oncology, for example. Group OT has shown really significant improvements in reducing fatigue and helping patients reclaim their identity beyond just being a cancer patient.
And that goes even broader, right? I saw that OT groups are now being looked at as a way to fight social isolation and loneliness.
It's a growing area, and it makes perfect sense. The simple act of doing a shared, meaningful task in a group that provides a benefit that goes way beyond just physical improvement. Now, if we think the group environment is important for OT, it's arguably even more critical for speech-language therapy.
Because you can't really practice talking in a vacuum.
You can't. Communication is social. It's an interaction. You can work on, articulating sounds by yourself with a therapist, but you can only practice a real conversation with other people.
So for ST, the group setting isn't just an efficient delivery model. It's part of the core therapy.
It is the therapy in many ways. The focus is on communication and social interaction in a naturalistic setting. And we have pretty good, moderate certainty evidence that Group ST improves communication and quality of life for stroke survivors.
Let's talk about aphasia. For someone struggling to find words, a one-on-one session with a therapist must feel like being under a microscope.
It can be incredibly stressful. That performance anxiety can just shut speech down.
So how does the group change that dynamic?
It completely changes it. The pressure is off. You're in a social context where communication happens naturally. You might respond to a peer or chime in on a shared activity. That intense focus is gone.
So the initiation of speech becomes easier.
Dramatically easier, and we see it increases social closeness too, especially in those early acute rehab settings. The encouragement you get from a peer who gets it is so powerful.
And are there specific techniques that only really work in a group?
Oh, absolutely. Think about something like acquired dysarthria, the motor speech issue we see in conditions like Parkinson's.
Okay.
Group therapy for that can include things like loudness-based techniques, almost like group chanting or even singing groups.
You can't really do choral speech by yourself.
You really can't. And for degenerative conditions like primary progressive aphasia, the expert consensus is that you need both. You need targeted individual therapy, and you need those ongoing conversational support groups to maintain social connection for life.
Okay, this is fascinating. So if PT groups are getting people moving, and OT groups are getting them back to their life roles, and ST groups are getting them communicating,
The logical next step is.
what happens when they all work together? This idea of interprofessional practice.
And the advocacy for this is it's incredibly strong. You read the literature, and everyone agrees that combining PT, OT, and ST should optimize outcomes, boost efficiency, and lead to better functional gains.
It's the rehab dream team, right? The movement expert, the activity expert, and the communication expert all working together.
Yeah.
The result seems like it should be, well, obviously superior.
It's so intuitive, you'd think the whole would be far greater than the sum of its parts.
But intuition doesn't always line up with the hard data, does it? Where does this beautiful idea run into trouble in the real world?
This is where we hit a really significant research gap, despite this overwhelming belief that it's the best way to go.
The studies aren't there.
The empirical research on true integrated interdisciplinary groups is surprisingly limited. We have the models we want to use, but we don't have this deep well of evidence yet that proves they're always better than separate care.
So if everyone agrees it's a great idea, why is it so hard to do? What are the barriers?
They really fall into two big buckets, logistics and role misunderstanding.
Let's start with logistics. That seems straightforward.
It is, but it's a huge hurdle. Just imagine trying to schedule 3 different therapists who all have their own caseloads, with a group of patients who all have their own needs and schedules. It takes a massive amount of administrative support.
Okay, so scheduling is a nightmare. What about the role misunderstanding? That seems more subtle.
It can be a real point of friction. For example, you have a group cooking task. The PT might be laser focused on the biomechanics of lifting a pot, the shoulder stability, the core engagement.
Right.
And they might look at the OT and wonder why they're not using a specific standardized weight. But the OT's priority might be totally different. For them, it's about the patient reclaiming the meaningful role of cooking, the confidence it builds, the social aspect of sharing a meal.
So they're literally using different yardsticks to measure success for the very same activity.
Exactly. And if that's not planned out carefully, who leads what the shared goals are, it can lead to confusion and inefficiency instead of synergy.
So the ideal is still a bit out of reach, not because it's a bad idea, but because the scaffolding needed to support it is just so complex.
Precisely. It's where we want to go, but we're still figuring out the map for how to get there consistently.
So after all this, what does it mean for you, the listener? We've seen 3 really distinct models for group therapy.
We have. Physical therapy groups are largely about exercise and function. The goal is maximizing movement and mobility.
Then you have occupational therapy groups, which are focused on activity and participation, all about getting you back to your meaningful daily roles.
And finally, speech therapy groups, which are focused on communication and interaction. They use the social setting itself as the main tool for recovery.
And while all of them seem to work, they're feasible, patients like them, they're often non-inferior to one-on-one care, there's an overarching problem with the research, isn't there?
There is. We have to end with that limitation, which is the sheer heterogeneity of it all.
Okay, unpack that. Why does heterogeneity matter so much?
It matters because it makes it incredibly hard to compare apples to apples. Think about it. One study on group PT might measure success by walking speed. Another might measure patient-reported confidence.
And those are 2 totally different things.
Completely different yardsticks. So when you have this huge variation in study designs, in the patient populations, and especially the outcome measures, it's very difficult to make broad, universal recommendations.
So the real challenge is that group therapy isn't one thing. It's a massive umbrella for dozens of different approaches.
Exactly. So since the research does consistently show that patients and providers are satisfied and that the efficacy is often comparable, the big question isn't really if group therapy works.
It's when does it work and for whom?
That's it.
All right, so let's leave you with a final thought to chew on. We know the success of these groups depends on more than just the exercises, the tasks. It's about the environment, the group culture, the support for the therapist running them.
Yeah.
And we've just talked about how hard it is to get that interprofessional model off the ground.
Yep.
So what specific shift, either logistically or culturally, do you think is most needed to finally bridge that gap between PT, OT, and ST? What would it take to finally deliver that ideal, evidence-backed, all-in-one group care we've been talking about? Think about what it takes to get 3 different experts to agree on one single yardstick. That's something worth mulling over.
Brought to you by Quaderno KO. Learn smarter, not harder.